Welcome to the Rad-Onc Smart Review GU Cancer Series.
Glad to be here, diving into this one.
Yeah, and today, picture this. Imagine trying to deliver a highly lethal, like millimeter-precise dose of radiation to a target that dynamically changes its volume.
Right, and not just by a little bit.
Exactly, but up to, what, 300% over the course of a single hour?
Yeah, it's wild.
And now complicate that by placing this expanding and contracting target directly against one of the most radiation-sensitive, highly mobile structures in the entire human body.
It's basically the ultimate biomechanical paradox in our field. I mean, truly.
It really is.
You are essentially forced to predict the unpredictable, and you have to do it for, 33 consecutive days.
Which is terrifying when you think about it.
Oh, absolutely.
Yeah.
Because if you calculate those vectors incorrectly, you aren't just missing the tumor. You're delivering a completely catastrophic dose to the small bowel.
Yeah, and that is the reality of the definitive bladder preservation workflow, which is our exclusive focus today.
It's a heavy one.
It is. We are synthesizing a massive stack of sources here. The Astro and Estro consensus contouring guidelines, the definitive trial publications for BEAST 2001 and BCON, and our own institutional workshop protocols.
Right, because we want to master one of the most technically demanding pelvic workflows in radiation oncology.
Exactly. The mission here isn't to simply recite a dose prescription,
No, anyone can look up a dose.
Right. We are breaking down the deep biological why and the technical how behind simulating, contouring, and really justifying every single decision you make for a moving organ.
Because if you don't understand the underlying physics of bladder deformation or the specific pharmacology of why we choose one radiosensitizer over another,
You're flying blind.
completely blind. You cannot safely execute this treatment. I mean, the margins for error are functionally zero.
Especially as we transition into hypofractionated and adaptive paradigms.
Oh, exactly. The tighter the margin, the higher the stakes.
So, to keep this grounded in clinical reality, we're running a single foundational case anchor through this entire discussion today.
I love a good case anchor. Let's hear it.
Okay, so you are sitting in clinic, and you're looking at the chart of a 68-year-old man.
Okay, 68.
He initially presented to his urologist with painless, gross hematuria.
Classic presentation.
Classic. The diagnostic cystoscopy revealed a solitary 3-centimeter high-grade urothelial carcinoma, and it's sitting squarely on the left lateral wall of the bladder.
Now, that location is a critical piece of data right there.
The left lateral wall.
Yeah, the left lateral wall gives us distinct biomechanical advantages compared to, say, a lesion on the dome or the trigone.
Which we will absolutely analyze in depth when we get to the contouring phase.
Looking forward to it.
So urology takes him to the OR for a maximal TURBT, and the operative note explicitly documents that the resection was visibly complete, all the way down into the deep detrusor muscle.
Excellent. That's exactly what you want to read.
Right. And staging is crisp, No extensive field CIS, no hydronephrosis.
Good.
Cross-sectional imaging shows N0 is 0. His baseline functional status is excellent, too. ECOG1, good baseline bladder capacity with minimal nocturia, and his creatinine clearance is sitting at 55.
Okay, 55. That's going to be important later.
Definitely. And finally, he is highly motivated to keep his native bladder.
Well, I mean, this is the textbook CT2 N0 M0 presentation.
Yep.
The multidisciplinary framework here requires us to present radical cystectomy and trimodality therapy as basically parallel Tier 1 curative options.
They sit right next to each other in the guidelines.
Exactly. But if he selects preservation, which his motivation clearly indicates, the absolute non-negotiable standard is that concurrent chemoradiation is mandatory.
Right, mandatory. We do not offer radiation alone for a medically fit patient with curative intent.
Never. The synergistic cell kill of the systemic agent is required to overcome the inherent radioresistance of urothelial carcinoma.
So let's aggressively break down that patient selection. Because offering trimodality therapy to the wrong biological candidate,
Oh, it's a disaster.
it's a setup for a highly morbid salvage cystectomy.
Yeah, you're doing him no favors.
So we use the mnemonic MTCH to define the ideal profile. MATCH is for maximal TURBT.
Right.
And I want to push on the biology here for you guys listening. Why is visually clearing the tumor so critical? I mean, is it just to give us a smaller target on the CT scan?
Oh, no. It's fundamentally about tumor hypoxia and tumor burden.
Okay, unpack that.
So a bulky, fungating bladder mass essentially outgrows its own blood supply.
Right, its vessels can't keep up.
Exactly. And that creates a profoundly hypoxic core in the center of the tumor. And oxygen is the primary radiosensitizer.
Right, we need oxygen to make radiation work.
Yeah, radiation relies on tissue oxygen to generate the reactive oxygen species that physically shattered the tumor DNA.
So if there's no oxygen,
If you leave bulk disease behind, you are irradiating an oxygen-starved radioresistant mass. The radiation it won't be as effective.
wow, okay. So the surgery actually changes the microenvironment.
Exactly. By performing a maximal turbine BT, the urologist removes that hypoxic bulk. They scoop it out, leaving behind only well-oxygenated microscopic residual disease in the highly vascularized muscle bed.
And then is where radiation excels.
Precisely. We are great at microscopic oxygenated disease.
That makes the surgical radiation interface incredibly clear. But let's look at the real-world scenario.
Right.
You open the operative note, and the urologist states the TURBT was incomplete.
Yeah, happens all the time.
Right. The tumor was like too broad, or the bladder wall was unusually thin, and they aborted to avoid a transmural perforation.
A very real risk.
So does that residual bulk automatically disqualify this 68-year-old from preservation?
It doesn't automatically disqualify him, particularly if he is, say, borderline medically fit for a 7-hour cystectomy.
Right. If surgery's super risky anyway.
Yeah, but it entirely shifts the risk-benefit calculus and your technical strategy.
Yeah.
With an incomplete TURBT, your local control probability plummets.
Because of that hypoxia we just talked about.
Exactly. And from a planning perspective, you completely lose the justification for a tight, high-dose focal boost.
Oh, interesting. Why is that?
Well, you can't boost a target, you can't confidently define, and an incomplete resection leaves a jagged, poorly defined volume of Gross disease.
You're just guessing where the edges are.
Right. So you are forced into a highly conservative, whole bladder, full dose approach, exposing much more normal tissue to the high-dose volume.
Makes total sense. Okay, let's continue through the MTCH profile. We covered the maximal TURBT. The A is the absence of extensive CIS or hydronephrosis.
Right.
Now, extensive CIS implies a field cancerization effect, right? The entire urothelial lining is genetically unstable.
Exactly. It's a field effect.
So if you focal boost the primary bed,
Another tumor will simply erupt on the contralateral wall 6 months later. You haven't solved the underlying regional instability.
right, and then hydronephrosis, I mean, that's an even more ominous mechanical sign.
Oh, it's a huge red flag. If the tumor is causing upstream dilation of the renal pelvis, it means it has structurally infiltrated and obstructed the ureteral orifice.
It's literally blocking the plumbing.
Right. And that implies a deep invasive biology, often extending through the serosa into the perivesical fat.
Yeah.
Those tumors behave aggressively and, honestly, their response to chemoradiation is historically dismal.
Okay, so M and A are covered. Moving on, T is for a T2 to CT3A solitary unifocal tumor, which our case anchor has.
A perfect fit.
Then C is for a concurrent chemo candidate, which we established is mandatory for synergy.
Absolutely.
Finally, H is for high baseline bladder function. And I have to say I see residents miss this constantly.
Oh, all the time. They get tunnel vision on the tumor.
Exactly. They look at the tumor staging, but completely ignore the functional history. If a patient is urinating 20 times a day with severe urgency before you even start treatment, I mean, 64 gray of radiation is going to induce a fibrotic, contracted bladder that functions like a thimble.
Yeah, and you have to remember, you preserve a bladder so the patient has a high quality of life.
Right. What's the point otherwise?
Exactly. If you, quote-unquote, cure the cancer, but leave the patient tethered to a toilet, passing blood and clots from severe radiation cystitis, you have failed the functional goal of trimodality therapy.
The baseline function basically determines the functional ceiling post-treatment.
Exactly. You never make a bad bladder better with radiation.
Such a great point. Okay, so our 68-year-old fits the M and ECH criteria perfectly. But even with the perfect candidate, we are immediately confronted with the core mechanical challenges of the pelvis.
The fun part.
The fun part. Let's analyze the 4 horsemen of bladder planning.
Yeah.
Horseman number 1 is movement and deformation.
Yeah, the biomechanics of the bladder are entirely unique in radiation oncology. It is a highly compliant visceral balloon, but it's constrained by rigid, bony anatomy anteriorly and a highly variable rectal vault posteriorly.
So it's squished between a rock and a hard place.
Literally. And as the bladder fills with urine, it doesn't just expand uniformly in all directions.
Oh, really? It's
Right.
not a perfect sphere expanding.
No, not at all. The bladder, neck, and trigon are relatively tethered by the pelvic floor and the urethra.
Right, they're anchored down.
Exactly. Therefore, the expansion vectors are directed superiorly toward the dome and laterally.
And the posterior wall is entirely at the mercy of the rectum.
Completely.
I look at daily cone beam CTs, and if a patient has a massive rectal gas bubble, the entire posterior wall of the bladder is shoved anteriorly by 2 or 3 centimeters.
Yeah, it completely distorts the geometry we mapped on the planning scan.
Which is terrifying. And this is why target reproducibility is the absolute obsession of the bladder workflow,
Right.
which leads directly into horseman number 2, tumor bed visibility.
Right, the invisible target.
Exactly. Because our 68-year-old had a phenomenal urologist who performed a maximal TUR-ABT, the macroscopic tumor is gone.
Which is great for the patient.
Great for the patient, a nightmare for us.
Wow.
You are staring at a post-surgical CT scan trying to contour the ghost of a tumor based solely on mucosal thickening and surgical artifact.
Yeah, it's humbling.
I always conceptualize this with a specific visual when I'm on the console. Planning this treatment is like trying to paint a microscopic bullseye on a water balloon.
I love that analogy.
But this water balloon randomly inflates and deflates between 0 and 400 cubic centimeters every single day.
Right.
And bringing in Holtzman number 3, that water balloon is sitting millimeters away from a boiling hot radiator, the small bowel.
Yes, the primary dose-limiting organ at risk, the radiator.
Yeah.
Its tolerance to radiation, specifically the TD505, right, the dose that causes a 50% risk of severe complication at 5 years, is drastically lower than the bladder muscle itself.
The bowel just can't take the hit.
No. When the bladder is empty, loops of ileum and jejunum fall directly into the true pelvis, draping right over the superior dome of the bladder.
Like a blanket.
Exactly.
Yeah.
If you use massive 2-centimeter planning margins to account for the bladder's random inflation, you are inevitably dragging those bowel loops into your high-dose target volume.
And what's the clinical result of that?
Oh, acute desquamation of the bowel mucosa. It presents as severe, intractable diarrhea during treatment, and then late risks of fibrotic stricture or even obstruction down the line.
Which makes the location of the tumor, our 4th horseman, so pivotal, right?
Hugely pivotal.
Our anchor case has a tumor on the left lateral wall. The lateral walls expand, yes, but they expand into the paravesical fat, not directly into the bowel space.
Right. Now contrast that with a tumor on the dome.
Oh, the dome.
A dome tumor is a dosimetric nightmare. The dome has the highest degree of spatial excursion depending on filling, meaning your internal target volume has to be incredibly generous superiorly.
Just to make sure you hit it.
Exactly. And what sits immediately superior to the dome?
The small bowel.
The small bowel.
Yeah.
You are forced into a direct conflict between adequately covering the microscopic disease and respecting the bowel constraints.
Yeah.
You almost always have to compromise, which is why dome tumors historically have higher rates of toxicity or, sadly, marginal miss.
Okay, what if the tumor is on the trigone? The trigone is relatively fixed, right? So movement isn't the big issue there.
Movement isn't the issue, but the anatomy there is structurally vital. The trigone is that triangular region at the base of the bladder defined by the 2 ureteral orifices and the internal urethral sphincter.
It's the plumbing epicenter.
Exactly, it's the plumbing epicenter. If you drop a radical 64-gray dose hotspot right onto the trigone, the resulting late fibrosis can scar down the urethral orifices.
Oh, wow.
Yeah, causing bilateral hydronephrosis and renal failure months or years after you've cured the cancer. It requires immense dosimetric respect.
That is terrifying. Okay, let's transition to the evidence-based treatment selection. We've defined the challenges. Now we need to select the radiotherapy backbone and the concurrent systemic agent. There are 2 highly defensible fractionation paradigms here.
You have the conventional paradigm, which is 64 to 66 gray, delivered in 32 to 33 daily fractions over about 6.5 weeks.
Standard long course.
Right. And then you have the modern hypofractionated paradigm, which is 55 gray, delivered in 20 daily fractions over exactly 4 weeks.
Okay, I want to dig into the radiobiology of why 55 and 20 has become so dominant, particularly following the BC-Con and BC-2001 data out of the UK. We know that urothelial carcinoma has a relatively low alpha-beta ratio compared to, say, squamous cell carcinomas of the head and neck.
Right. It behaves more like prostate cancer in its sensitivity to fraction size.
Exactly. So how does that play out clinically?
Well, the alpha-beta ratio dictates how a tissue responds to the size of the daily dose. Because urothelial carcinoma is uniquely sensitive to larger daily fractions, stepping up the daily dose from 2 gray to 2.75 gray, which is what we do in the 55 and 20 regimen, achieves a highly potent biologically effective dose, or BED, for the tumor.
And it does that without requiring 7 weeks of treatment. Exactly. From a health economics and a patient quality of life standpoint, cutting the treatment time nearly in half is a massive victory.
But, and this is a big but, the hypofractionated approach removes your safety net.
Oh, completely.
If you are delivering 2.75 grays per day, you are burning through the small bowel tolerance much faster.
Yeah, the normal tissue doesn't like that higher fraction size.
Right, so you cannot attempt 55 and 20 if you are relying on, like, weekly 2D kilovoltage x-rays for setup. It absolutely mandates daily, high-quality volumetric image guidance.
If you don't have daily cone beam CT to visualize the soft tissue interface between the bladder wall and the bowel every single day, you must revert to conventional fractionation. The higher fraction size is unforgiving.
So true. Let's discuss the target volume itself now. The traditional approach was to treat the entire bladder plus the pelvic lymph nodes.
Right.
But for a node-negative case like our 68-year-old, treating the elective pelvic nodes is no longer universally mandated. I actually see many centers treating bladder-only fields. Yet, the shift toward bladder-only fields in highly selected node-negative patients is driven by the failure patterns.
What do the patterns show?
If you look at the long-term recurrence data for clinically N0 patients who undergo trimodality therapy, the vast majority of failures are either local, meaning within the bladder mucosa itself, or they represent distant hematogenous micrometastatic spread to the lungs or liver.
So they aren't failing in the pelvic nodes.
Rarely. Isolated pelvic nodal failures in the absence of a local recurrence are remarkably rare.
Wow.
Therefore, irradiating the entire pelvic nodal basin introduces profound gastrointestinal and hematologic toxicity without a clear overall survival benefit. It is an entirely defensible, evidence-based choice to omit the nodes and spare the bowel.
Which brings us to the most debated nuance of the target volume. The reduced high-dose volume approach that was tested in the BC 2001 trial.
Oh, this is a big one.
The concept is elegant, right? You treat the whole bladder to a moderate dose, say 40 gray, to cover any microscopic field disease, and then you come down and deliver the remaining high dose exclusively to the tumor bed on the left lateral wall.
Right, the focal boost.
But I constantly see residents misinterpret the statistical outcome of BC 2001. Did that trial definitively prove that this reduced volume approach is non-inferior for local control?
It absolutely did not, and this is a vital biostatistical distinction. The BC 2001 trial was a brilliant piece of literature, but it was essentially a trial of two halves.
Okay, break that down for us.
So one randomization was for the chemotherapy radiotherapy alone versus chemoradiation, which definitively proved the superiority of adding chemotherapy.
Right, we all know that part.
Exactly. But the second randomization compared whole bladder full-dose radiotherapy against the reduced high-dose volume approach.
And what were the actual statistical mechanics of that second randomization?
The trial was designed to show non-inferiority for the reduced volume approach regarding local control. However, the confidence intervals in the final analysis actually crossed the non-inferiority margin.
Oh, so it technically failed.
Strictly speaking, yes, it failed to formally prove non-inferiority.
Wait, really? But everyone uses it.
I know. The local control rates were numerically very similar. There wasn't like a massive drop-off, and the toxicity profile was highly favorable, which is why the approach was rapidly adopted. But from an evidence standpoint, whole bladder full dose remained the unassailable gold standard.
Especially if you have any doubt whatsoever about the exact location of the tumor bed.
Exactly.
I apply that exact logic in the clinic. If the urologist placed photoceal markers and the operative note is pristine, I will use a reduced high-dose volume boost because my localization confidence is 100%.
Sure, yeah.
But if it's a blurry, poorly documented trigone lesion, I will not risk a marginal miss just to save a few cubic centimeters of normal tissue. I will treat the whole bladder to 55 gray.
That is the exact right clinical instinct.
Okay, let's pivot to the systemic radiosensitizer. We established concurrent chemo is mandatory. The historical heavyweight champion here is cisplatin.
The heavy hitter.
But we have to look at our anchor patient's baseline labs. His creatinine clearance is 55 milliliters per minute.
And that creatinine clearance of 55 immediately flags a major toxicity risk.
Because of the kidneys.
Right. Cisplatin is primarily excreted through the kidneys, and it is notoriously nephrotoxic. The standard threshold for safe cisplatin administration in most medical oncology suites is a creatinine clearance strictly above 60.
So he's just under the wire, but in a bad way.
Yeah. If you push cisplatin in a patient sitting at 55, especially an older patient who might become dehydrated from radiation-induced diarrhea.
Which happens all the time.
All the time.
Yeah.
You risk tipping them into acute, irreversible renal failure.
So we consult our medical oncology colleagues, and we need an alternative. What is the pharmacological mechanism we rely on if cisplatin's off the table?
The most robust, evidence-based alternative, which, again, was the regimen utilized in the BC 2001 trial, is the dual-agent combination of 5-fluorouracil, or 5-FU, and mitomycin C.
Okay, I want to break down exactly how those two drugs work in concert with the radiation beam, because the synergy is fascinating.
It really is.
Let's start with 5-FU. It's an anti-metabolite, right? It acts as a thymidylate synthase inhibitor.
Right.
Essentially, it starves the cancer cell of the thymidine. It needs to repair the DNA double-strand breaks caused by our radiation photons.
Exactly. It halts the cell cycle in the S phase.
Right, which forces the tumor cells to remain in a state where they are highly vulnerable to the next fraction of radiation.
And then you introduce mitomycin C, which is just a brilliant complement.
So?
So, mitomycin C is an alkylating agent, but crucially, it is a bioreductive drug. It actually requires a hypoxic environment to become fully activated into its cytotoxic form.
Wait, a hypoxic environment? But didn't we just say radiation is terrible at killing hypoxic cells?
Yes, that is the genius of it. While radiation is highly effective at killing the well-oxygenated tumor cells on the periphery, it struggles against the hypoxic core of any residual microscopic disease.
Oh, wow.
Mitomycin C specifically targets and destroys those hypoxic radioresistant cells.
So they cover each other's blind spots.
Perfectly. The combination of 5-FU preventing DNA repair, mitomycin C clearing the hypoxic zones, and daily radiation ablating the oxygenated tissue. It creates a devastatingly comprehensive localized attack.
That is so elegant.
Yeah.
And functionally, for our 68-year-old, the 5-FU and mitomycin C regimen is highly tolerable with a creatinine clearance of 55.
Very tolerable.
Now, another increasingly common alternative, particularly in North America, is twice-weekly gemcitabine.
Yes, seeing that a lot more.
Right. Gemcitabine is a powerful nucleoside analog that incorporates directly into the DNA strand, causing chain termination and profound radiosensitization, and it is also very gentle on the kidneys.
Yeah, the key takeaway is that the choice of agent must be meticulously tailored to the patient's renal function and overall physiology.
Yeah.
You can't just autopilot cisplatin.
Absolutely. Okay, let's move into the simulation and the actual mechanics of target definition.
Look at it.
You are the attending. You bring the 68-year-old down to the CP simulator. What is the overarching philosophy driving your setup?
The absolute governing principle, the law of bladder simulation, is reproducibility over heroic perfection.
I see residents violate this constantly.
It's a rite of passage to get this wrong at least once.
They look at the anatomy and decide they want to push the small bowel completely out of the pelvis, right? So they instruct the patient to drink exactly 500 milliliters of water, wait exactly 45 minutes, and scan them with a massively distended full bladder.
And it looks beautiful on that single planning CT.
It looks pristine.
The dome is elevated. The bowel is displaced superiorly. You think you've solved it. But the biological reality of a 68-year-old man who just underwent a surgical resection of his bladder wall is that his detrusor muscle is highly irritable.
Right.
He is experiencing spasms. Attempting to reproduce that exact 500 milliliter volume every single day for 20 fractions is an exercise in futility. Some days he'll hold 200 cc, some days he will barely hold 50 cc because the urgency is too severe.
And when the volume fluctuates like that, your beautiful treatment plan completely falls apart.
It goes right out the window.
The target moves entirely out of the high-dose fields, and the small bowel collapses back down into the path of the beam. You achieve a marginal miss and bowel toxicity simultaneously.
The worst of both worlds.
So how do we establish a genuinely reproducible baseline?
The paradigm has heavily shifted toward an empty bladder protocol, particularly if you were utilizing the 55 in 20 hypofractionated regimen.
Okay, what's the workflow for that?
It's remarkably simple. The patient voids immediately before the simulation scan, and they void immediately before getting on the table for every single daily treatment.
Now, the counter-argument to the empty bladder is immediate. Doesn't an empty contracted bladder allow the small bowel to sink directly into the true pelvis, resting right against the target?
It does. It absolutely brings the bowel anatomically closer to the bladder.
So why is that better?
Because the empty state is phenomenally reproducible. An empty bladder today is volumetrically almost identical to an empty bladder tomorrow.
Ah, because there's nowhere lower for it to go.
Exactly. Because the organ is not inflating and shifting wildly, The inherent geometric uncertainty is drastically reduced.
Right.
Therefore, instead of placing a massive 15 mm planning target volume, or PTV, margin around the bladder to account for filling variations, you can confidently shrink your margin to 5 or 7 mm.
Wow, that's a huge reduction.
And that tight conformal margin ultimately spares far more cubic centimeters of small bowel than you would have saved by trying to distend the bladder.
You trade a macroscopic anatomical separation for microscopic, highly reproducible dosimetric precision.
Perfectly said.
Okay, what about the posterior interface? How do you manage the rectal protocol during simulation?
Well, the rectum is the primary engine of posterior displacement. If the rectal vault is dilated with, say, 4 centimeters of gas or stool during the simulation, it acts as a wedge. It pushes the entire bladder anteriorly toward the pubic symphysis.
Right.
If the patient then has an empty rectum on day 3 of treatment, the bladder falls backward, completely exiting the anterior border of your PTV.
So you completely miss.
Exactly. To mitigate this, we keep it practical. We often recommend a mild fleet enema before the simulation scan and counsel the patient on maintaining consistent dietary habits to regulate bowel gas.
So no specialized diet.
We don't need a pristine surgical-level bowel prep. We just need to eliminate gross volumetric extremes.
And from an imaging standpoint, intravenous contrast during the simulation is a massive asset.
Oh, yeah. If their kidneys can take it.
Right, assuming the creatinine clearance of 55 allows for a judicious dose of non-ionic contrast. Timing the scan for the portal venous or early expiratory phase brilliantly highlights the mucosal enhancement of the bladder wall and delineates the exact thickness of the detrusor muscle.
It really pulls the bladder out from the surrounding pelvic soft tissue.
So we have an excellent reproducible empty bladder CT scan. Now we have to actually draw the target. We are looking at an empty bladder on the screen. The tumor is gone due to the maximal TURBT.
The ghost town.
We need to contour the left lateral wall tumor bed for our focal boost. If a resident just looks at the CT scan and draws a circle around the thickest part of the wall,
they're going to fail the board exam and potentially fail the patient.
seriously.
Contouring a resected bladder tumor is the ultimate exercise in clinical integration. You cannot rely on a single modality. You must synthesize 4 distinct data streams to triangulate the true tumor bed.
Let's walk through that triangulation process step by step. Data stream number 1 is the cystoscopy report and map.
Right, the urologist creates a visual map during the diagnostic cystoscopy, typically drawn on a 2D template. This confirms the gross quadrant, the left lateral wall.
Got it.
But a 2D drawing does not translate perfectly to a 3D axial CT dataset, especially because the bladder was distended with saline during the cystoscopy and is now collapsed on your simulation scan.
Which makes data stream number 2, the detailed operative note, so critical. You cannot just read the summary. You have to read the body of the surgical dictation.
Exactly. You are looking for spatial relationships to fixed anatomical landmarks. Did the surgeon dictate that the inferior margin of the tumor was exactly 2 centimeters superior and lateral to the left ureteral orifice? Did it extend anteriorly toward the bladder neck?
You're basically looking for coordinates.
Precisely. The ureteral orifices and the bladder neck are your fixed, non-compressible navigational beacons. You locate those on your CT scan, and you map the coordinates described in the OR.
Okay, data stream number 3 is the simulation CT itself, where you look for the surgical artifact, right? Focal wall thickening, post-surgical edema, or even tiny pockets of gas trapped in the resection crater.
Yeah, those are great clues. And finally, data stream number 4 is any pre-TURBT imaging. If the patient had a diagnostic CT urogram or a multiparametric MRI before the surgery, you physically fuse that preoperative scan to your planning simulation scan.
How does the fusion work since the bladder volumes are different?
By aligning the pelvic bones and the fixed prostate or vaginal anatomy, you can project the ghost of the gross tumor volume directly onto your postoperative target.
It is a meticulous process of cross-referencing.
Very meticulous.
Now, we often get asked about the role of fiducial markers. We place gold seeds in the prostate every day. Can the urologist place markers in the bladder wall?
They absolutely can, and it is a phenomenal technique when available. During the TURBT, the urologist can inject lipiodol, a highly radio-opaque iodinated contrast agent, directly into the submucosa surrounding the resection bed. Or they can deploy tiny fiducial coils.
That sounds incredibly helpful.
Oh, it is. These markers show up with brilliant clarity on both the simulation CT and the daily cone beam CTs. They act as direct, unmistakable beacons for the tumor bed.
But the caveat here is critical for anyone listening preparing for oral boards. You cannot present fiducial markers as a universal mandatory standard of care.
Correct. The placement of bladder fiducials requires specific urologic training and highly specialized equipment that is not available at every community center.
Right.
If you tell an examiner that you cannot plan a bladder preservation case without Lipiodol, you demonstrate a lack of real-world adaptability. They are a highly valuable adjunct that increases your confidence in margin reduction, but you must be fully capable of executing the clinical integration of the operative notes and imaging if markers are not present.
So we've localized the target. Now we have to wrap it in a planning target volume, the PTV margin, to account for the daily mechanical variations. This is where the physics of image guidance dictate the biology of organ sparing.
Yeah, this is the crux of it.
How large should our margins be?
Margin size is a dynamic variable. It is mathematically dictated by the exact modality of image-guided radiotherapy, or IGRT, that you utilize at the machine.
Give us an example.
Let's look at the historical standard, 2D kilovoltage X-rays. If you only take planar X-rays before treatment, you can align the pelvic bones perfectly, but you have zero visibility of the actual bladder soft tissue.
You're just matching bone to bone.
Exactly. You don't know if it's full, empty, or pushed sideways by the rectum. To ensure you don't miss the target under those blind conditions, you are forced to use massive isotropic margins of 1.5 to 2.0 centimeters.
And as we established, a 2.0 centimeter margin in the superior direction is guaranteed to engulf massive volumes of small bowel.
Yeah. The toxicity profile of that approach is what gave bladder radiation a bad reputation in the 1990s.
Exactly. But if you implement daily volumetric IGRT specifically, a cone beam CT, the entire paradigm shifts.
9 a day.
With a daily cone beam, you acquire a 3D soft tissue dataset while the patient is on the table. You can directly visualize the detrusor muscle, the rectum, and the overlying bowel loops. You can physically verify that the bladder volume matches the simulation volume.
Right.
Because you eliminate the setup uncertainty and the volumetric guesswork, you can safely compress your PTV margins down to 5 to 7 millimeters.
But what happens when you take that daily cone beam CT and the bladder is wildly different? Let's say the patient drank a cup of coffee, the bladder is spasming, and it's half the size it was at simulation. Even with a 5 millimeter margin, the anatomy no longer matches the dosimetry. How is the field evolving to solve the day-to-day deformation problem?
The technological evolution here is breathtaking. We are moving heavily into plan-of-the-day libraries and online adaptive radiotherapy.
Okay, tell us about the plan of the day.
In a plan-of-the-day workflow, the dosimetrist doesn't just create one plan. They create an entire library of plans for the same patient. They create a plan optimized for a small 50 cc bladder, a plan for a medium 150 cc bladder, and a plan for a large 300 cc bladder.
Oh, that's clever.
Right. So every single day, the radiation therapists acquire the cone beam CT, assess the actual volume of the bladder in that exact moment, and literally select the plan from the library that perfectly hugs that day's anatomy. It eliminates the need for a single, massive margin designed to cover all possibilities.
It's highly effective. But the absolute cutting edge is true online adaptive radiotherapy, utilizing MRI Linux or AI-driven cone beam Linux.
Right, where you don't even need a pre-made library.
Exactly. In this workflow, there is no pre-made library. The patient lies on the table, we acquire a high-resolution scan, and an artificial intelligence algorithm immediately auto-segments the new shape of the bladder, the rectum, and the small bowel.
While they're on the table.
Yes. The physician reviews and adjusts the contours in real time. Then, the computer re-optimizes and calculates an entirely new custom radiation plan in a matter of minutes.
It is bespoke radiation delivery sculpted to the anatomy of the minute. By adapting the dose distribution to the daily deformation, you achieve unparalleled sparing of the small bowel.
It's the future, for sure.
Let's synthesize all of this back into our anchor case. Our 68-year-old left lateral wall tumor, maximal TURBT, CRCL of 55. I want your definitive, start-to-finish clinical plan.
All right, here's how I'd run it. We proceed with an empty bladder protocol to maximize target reproducibility. He voids immediately prior to the simulation scan and daily treatments.
Oh,
We utilize fiat contrast during the sim to map the mucosal definition.
love it.
I will meticulously integrate the cystoscopy map the urologist operative dictates and his pre-op imaging to localize the left lateral wall tumor bed. Because the TURBT was visibly complete and the location is mechanically favorable, I'm highly confident in a reduced high-dose volume approach.
And the dose and systemic therapy.
I will prescribe the hypofractionated regimen of 55 gray in 20 fractions. I will deliver 40 gray to the elective whole bladder to cover microscopic field disease, and simultaneously deliver a focal integrated boost to the left lateral tumor bed to achieve the full 55 gray.
Excellent.
And the chemo. Due to his creatinine clearance of 55, I will coordinate with medical oncology to deliver concurrent 5-fluorosil and mitomycin C. Finally, we will mandate daily cone beam CT for precise soft tissue alignment and margin reduction to rigorously protect his small bowel.
That is the architecture of a flawless, modern, biologically optimized plan.
Thank you.
But to truly test the limits of our management logic, we must push the parameters until the system fractures. I am going to radically alter the presentation of our 68-year-old man. We are entering the contrast case.
Oh boy. Let's stress test it. What are the new variables?
He is the same 68-year-old good performance status, CRCL of 55. But the tumor location is no longer the pristine left lateral wall. The cystoscopy reveals a broad, infiltrating mass directly overlying the trigone, involving the right ureteral orifice.
Okay, bad location.
In fact, he presented with severe right-sided hydronephrosis, and urology was forced to place a ureteral stent to salvage his kidney function. He undergoes the TORA-BT, but the urologist calls you from the OR. The tumor was too expansive, the stent was obstructing access, and they had to stop. It is a documented, incomplete TORA-BT.
Man, that is a complete subversion of the MTCH criteria. You have an incomplete resection, hydronephrosis, and a biologically hostile location.
The first, most foundational question: does this catastrophic presentation definitively exclude him from attempting trimodality therapy? Must he go to surgery?
It does not absolutely exclude him from radiation, and this is where clinical judgment supersedes rigid algorithms.
Right.
If his cardiovascular status or age makes a 7-hour radical cystectomy with a urinary diversion an unacceptably high-risk procedure, or if he fundamentally refuses the surgery after extensive counseling, chemoradiation remains the standard of care. You do not abandon the patient.
But things change.
Oh, absolutely. The expectations of cure plummet, and the technical execution of the radiotherapy must drastically pivot.
Let's talk about that technical pivot. How does your contouring and dose strategy change when you face an incomplete resection on the trigone?
The elegant, reduced high-dose volume focal boost is immediately abandoned. You cannot safely target a tight boost volume when you have a bulky, jagged mass of gross residual disease wrapped around a ureteral stent.
The imaging must be awful.
It is. The stent itself introduces profound artifacts on the daily cone beam CT, completely degrading your image quality. Furthermore, the trigone location means the bulk of the disease is sitting directly on the bladder neck and internal sphincter.
Right. We talked about this earlier.
If you attempt to drop a concentrated high-dose hotspot onto that anatomy, the resulting fibrotic scarring will obliterate the ureteral orifices and the urethra.
So you revert to a blunt force approach.
Exactly. I shift to a highly conservative whole bladder full dose strategy. I will treat the entire bladder volume to the definitive dose. Depending on the sheer volume of normal tissue involved, I might even abandon the hypofractionated 55 and 20 regimen.
Really? Going back to the long course.
Yeah, treating a massive volume of the trigone and bladder neck to 2.75 grays per day carries an immense risk of late stricture. I would strongly consider reverting to the conventional 64 gray in 32 fractions to soften the daily biological impact on the surrounding healthy mucosa while still achieving the total curative dose.
This shift in strategy necessitates a very different conversation during the consultation, right? The shared decision-making process becomes much more complex.
It is a sobering, incredibly transparent conversation. You must explicitly look the patient in the eye and explain that the combination of his hydronephrosis, the stent, and the incomplete resection means his tumor is biologically aggressive and mechanically shielded.
That's a tough conversation.
It is. You counsel him that while you're delivering a curative regimen, his statistical likelihood of achieving a durable, complete response is significantly lower than the ideal candidate. He must psychologically prepare for the reality that the likelihood of requiring a salvage radical cystectomy in the next 2 years is exceptionally high.
That reality leads directly into our final phase, surveillance and salvage. The entire safety net of the definitive bladder preservation paradigm rests entirely on what happens after the radiation stops. Follow-up is not a formality. It is literally a matter of life and death.
Trimodality therapy is only a safe alternative to upfront surgery if you catch local failures early enough that the surgical window remains open.
Right.
If you lose the patient to follow-up and the tumor recurs and invades the pelvic sidewall, they become incurable. The surveillance protocol is obsessive and requires a tightly coordinated, multidisciplinary team.
Break down the exact timeline and mechanics of that surveillance.
The patient requires rigorous, direct visualization via cystoscopy by the urologist every 3 months for the first 2 years, spacing out slowly thereafter.
Every 3 months?
Yes, they require routine urine cytology to screen for high-grade malignant cells shedding from microscopic mucosal recurrences. And they require serial cross-sectional imaging CT scans of the chest, abdomen, and pelvis to monitor the urothelial tracts and screen for nodal or hematogenous metastatic spread.
Now, let's inject a clinical pearl regarding how we manage those recurrences, because not all failures are created equal.
Very true.
Let's say at the 9-month cystoscopy, the urologist visualizes a small, recurrent lesion. They biopsy it, and the pathology returns as a superficial, non-muscle invasive Ta or T1 recurrence.
This is a critical biological distinction. A non-muscle invasive recurrence does not automatically dictate the removal of the bladder.
Really? Even after full-dose radiation?
Yes, the radiation treated the deep muscle bed, but the superficial mucosa remains susceptible to new field defects. Highly selected non-muscle invasive recurrences can frequently be managed conservatively with a repeat TURBT, or with intravesical therapies like BCG installations, successfully keeping the native bladder intact.
But the clinical trajectory violently shifts if that biopsy returns as a muscle-invasive recurrence.
A muscle-invasive recurrence in a previously irradiated field is the ultimate high-stakes failure pattern. It means the biology of the tumor has outmaneuvered the chemoradiation.
So what's the plan?
In this scenario, there is no debate. A muscle-invasive recurrence equals an immediate recommendation for a salvage radical cystectomy, assuming the patient remains medically operable.
No exceptions.
No exceptions. You do not attempt reirradiation. You do not attempt intravesical chemotherapy. The definitive surgical window is closing rapidly, and the bladder must be removed to save the patient's life.
It is an absolute non-negotiable line in the sand.
Completely.
Before we wrap up this session on the bladder workflow, we are going to run a board-style rapid review. I will fire the major decision branches at you, and I want the synthesized board-defensible logic. Ready?
Ready? Let's run it.
First, define the absolute best candidate profile for definitive bladder preservation.
We use the mnemonic MTCH, maximal visibly complete 2RBT, absence of extensive CIS or hydronephrosis, solitary T2 to CT3A tumor, concurrent chemo candidate, and high baseline bladder function.
Second, what are the 2 primary evidence-based radiation dose fractionations?
The modern hypofractionated standard of 55 Gray in 20 fractions, leveraging the alpha-beta ratio, or the conventional protracted approach of 64 to 66 Gray in 32 to 33 fractions.
Third, radiation alone versus concurrent chemoradiation.
Concurrent chemoradiation is absolutely mandatory for any patient medically fit to receive it. Radiation alone is an inferior, non-standard approach for curative intent.
Fourth, what is the mandatory targeting rule for defining the focal tumor bed?
Clinical integration. You cannot rely on a single image. You must meticulously triangulate the cystoscopy map, the detailed anatomical coordinates of the operative note, the post-op planning CT, and the fused pre-op diagnostic imaging.
And fifth, what is the primary dose-limiting organ at risk that dictates our entire PTV margin and daily imaging strategy?
The small bowel. Its extreme radiosensitivity is the primary driver behind empty bladder protocols, daily cone beam CT requirements, and the push toward adaptive radiotherapy.
That rapid review perfectly crystallizes the mechanical and biological logic of the entire workflow.
It really pulls it all together.
As we close, I want to leave everyone listening with a final, highly provocative thought about the frontier of this field. We have spent an hour dissecting the physics of organ deformation and the necessity of margins.
Right.
But as online MRI and AI-driven adaptive radiotherapy approaches true real-time visualization where we can track the exact millimeter-perfect shape of the detrusor muscle every single second the beam is on, we are rapidly approaching an era where our geometrical PTV margins might drop to absolute zero.
It represents the complete subjugation of the biomechanical problem.
But here's the profound question. If we actually achieve zero margin treatment, perfectly painting the muscular wall of the bladder without a millimeter of spillover, will we suddenly discover that the microscopic invisible tumor cells we are trying to cure actually migrate and move independently of the gross bladder wall?
That is a wild thought.
Are we so obsessed with tracking the macroscopic muscle that we are ignoring the microscopic biology of the paravesical lymphatics?
That is the ultimate biological horizon. We are utilizing multi-million-dollar physics to solve a mechanical problem, but the microscopic cellular behavior might still outsmart us. It challenges the very foundation of what we believe we are targeting.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radong's Smart Review for our next episode. Thanks for tuning in.